So as I was saying, that is basically what universal health coverage is all about. It's making sure that everyone, whether you're rich, you're poor, you're black, you're white, whatever continent you find yourself, you should be able to afford the very basics of healthcare services without spending so much money. And this target has been set for 2030, meaning we are just 5 years, 5 years 5 years to go to achieve that such an ambitious goal. So what you commonly hear is things like UHC 2030, meaning by the year 2030, most of these countries, if not all, should have achieved this ambitious yet humanitarian goal. And of course, it has been problematic because we can all bear witness to the fact that there are so many changes or there are so many things that has to be put in place when it comes to achieving such a task, particularly in the global south. This particular here, we are going to be focusing a lot on financing because, as we all know, for those of us that have been following up the news, there's been a lot of issues regarding financing health services or health programs, particularly in Africa. And it is no news that world powers like the United States cut off significant funding to certain programs earlier this year. And that definitely affected a lot of people and a lot of health workers as well. So universal health coverage has been a struggle, and for those that are coming from Cameroon, we've seen some movements in terms of health insurance, in terms of different policies that have been put in place in trying to achieve this goal. So for this webinar, we are going to be using a multidisciplinary approach, meaning we're not just going to be talking about health. We have an expert on gender, we have an expert in health insurance, we have a medical doctor, we have an epidemiologist on board. So we're going to be looking at the different these different fields with respect to universal health coverage and to analyze how far Africa has gone in trying to achieve this very, very ambitious goal. So without wasting so much time, we are going to move into our first panelist in the person of Mr. Lowe. And Mr. Lowe has a lot of expertise in health insurance. So we are very much pleased to have you, Mr. Lowe, to be able to share your experience. The good thing is health insurance is something that a lot of people still don't know about when it comes to how health insurance works. And I was very intrigued when I worked on health insurance because that was one of the things I worked on while doing my thesis. And I was very intrigued to find out that even health personnel, doctors at the hospitals, had no clue what health insurance was all about. I mean, they were very clueless as to the different kinds of health insurance that exist. They were very clueless as to how it works and even the benefits. So I think a lot of us still don't really understand the concept of health insurance. So what is health insurance in the very, very basic and very layman of terms? What is meant by health insurance, and what are the different types of health insurance? Who benefits from these health insurance schemes? Who is funding these health insurance schemes? At the level of Africa, of course, maybe you can just run us through this basics so that we familiarize ourselves with these concepts before we go ahead.
Yes, thank you, Dr. Ada. I am Patrick, and I'm happy to be here. Universal health coverage, it's a significant topic which needs to, we need to continue this discussion so that we can get somewhere. On health insurance, yes, like you mentioned, several people don't understand the concepts. And insurance in general, it's something that changes very fast. And therefore, as the world changes, we try to change and adopt with how it goes. So health insurance in basic terms, it's giving insurance to those who fall sick. And now it's going to lead me now to break down what insurance is. Insurance is a risk pooling mechanism whereby people, industries, or individuals come together to put in resources in terms of premiums. And in the event of any circumstance or uncertainty, in this case, illness, now the monies put together would be used to cater for those who are in those difficult moments. And now you would realize that it's the funding is coming from its members. Now you put in money into a system, and now that same money is used to treat people. That same money is used to cater for the insurance overruns. And It's really growing, especially in cities like big cities. I'm not going to limit myself only to Cameroon, but now we realize that it's not spreading to the regions. And of course, I know for sure that is not why I'm answering this question, but I'm just to give you an overview. And so the types of health insurance would take it from the private to maybe the corporate. And now would start with the private would mostly see something like community-based health insurance. Many of us are familiar with the concept Jangi or Osusu, and I'm going to look at health insurance in that aspect because if you understand how these Osusu and Jangis work, it's basically how health insurance works. And so people come in, they put the monies and contribute for a particular cause. And at the end of it all, now, if there's anything that happens, that same fund is being utilized to cater for it. And now, when I talk of community-based health insurance, is these Jangis or these Osusus can be linked to that. Now, look at it from the other aspect of um, you now taking up a health insurance policy. That's another type. Now, these health insurance policies can be broken down again to private and corporate, where a family can come together and decide to insure each member, or organizations do insure their employees and their respective families. And we see mostly what is applicable today, it's mostly corporate because now for families it becomes challenging to actually get the right funding. Of course, the question of how much then will you contribute to be able to cater for yourself when you or when a member falls sick comes to play. And I think when I mention the community base, it's important to cite certain examples. Apart from the Jangis, we also have um, the the churches or for example, the Catholic mission or the Baptists that are coming up with schemes specialized to cater for something like the health insurance. And in an example here in Cameroon, we have BEFA, which is a health insurance scheme for the ecclesiastical province in Bamenda. And now you see that when these things are put in place, it goes a long way now to contribute now to the universal health coverage in its own way and its own specifications. I hope Ada have been able to cover that question.
Yes, thank you so much. I think while you were explaining, one question just popped in my mind. How
Okay.
how much of health insurance do the masses actually know about? Like I said, I for one, I personally discovered a lot of health insurance schemes when I
Africans,
was doing
are you getting?
Yes, I can hear you.
I actually discovered a lot of health insurance schemes while I was doing my thesis. So, based on your experiences and direct work with this field, how informed, how much of information do you think the public has? Because, like I mentioned, a lot of people don't know the different health insurance schemes that exist. I mean, those that are privileged to work in NGOs and private organizations, sometimes it's mandatory that these organizations insure their workers. But now, for most of those that find themselves in the informal sectors, which I think majority of most populations, especially in Cameroon and most global south countries, find themselves, how much of information do you think how much work is being done? Let me rephrase. How much work is being done to inform the public on what exactly is health insurance and how they can benefit? And I know that health insurance has different levels. Maybe you can just take 2 minutes to just quickly brief us so that people here who are part of this meeting, at least they can have an idea that these are maybe some health insurance schemes that exist and why should we be interested in health insurance? I mean, if my company doesn't give it to me, of what importance is health insurance? What do I stand to benefit from health insurance? Because we're talking about universal health coverage. We're talking about lessening the health burden. So how does this insurance go a long way to lessen my health burden? Does it mean if I'm insured? I just want us to have that very basic and global picture about health insurance before we move on.
Okay, now coming to awareness, yes, in general, Africa's insurance awareness is low, and health insurance falls also inside this category. It's a global or it's an African concern because the awareness generally it's below 2%. Few countries in Africa, South Africa, close to or getting towards 10%, but it's still below 10%. And you see countries like Cameroon, Nigeria, they are lingering around 1%. And this tells the nuanced story. You see, so the awareness is it's an issue. However, word to mouth has played a lot in this. And now the respective religious movements. Now they are coming up with these individual schemes, even community-based schemes like the Jangis, the Osusus. They're coming up with it. And if you want to look at it, but now we see that these smaller community initiatives that also act like health insurance are not even, or most at times, people don't really realize that that's a form of health insurance. And therefore, that awareness again is not available. So we do not get to capture that data from those sources. However, I think now what is needed to be done is to throw more light in the aspect that whatsoever you're doing that falls under this framework is a kind of or is a form of health insurance. And I think if now the data could be, captured in that aspect, we could see that awareness coming up strong, maybe using social medias and other mediums to
Okay.
communicate.
Thank you. Before I leave you, I still have one. Let's try to do more justice to health insurance a little bit. So now we've spoken about the fact that awareness is extremely low, and that is very true. That is very practical because, like I earlier mentioned, even health practitioners themselves who are in charge of patients that are insured are not aware of the different health insurance schemes that exist. So that's even a problem because we have situations where patients go to a certain hospital and the doctor is not even aware of what you're talking about and bureaucracy around navigating the health insurance processes and all that. Now, we are looking at the intersection of health and equity here. And we're talking about universal health coverage. Let's not forget the main thing, the central thing is universal health coverage, which means ensuring no one is left behind. So how then, or what are the design features of most health insurance schemes to ensure that this insurance reaches even the poorest and the most marginalized populations rather than focusing on just the privileged ones? Because if we're talking about leaving no one behind, we're talking about inclusivity, we're talking about equity. What is being done? What are some of these features that in this health insurance scheme that is making sure that the people that actually really do need financial coverage are actually getting it?
Okay, we need to embrace digital solutions. And Africa's population is growing. It means also that its digital population is growing. And embracing digital solutions is actually going to create that niche of increasing this awareness. We have health apps, digital health apps that are coming up strong and that are giving again some form of health insurance. In fact, these digital apps are partnering with insurance companies to go wide and far with providing health solutions. And now you would see that embracing digital networks or digital means to promote health schemes, it's going to go extremely fast. And one of those ways, or some of these schemes, or some of these digital solutions that we have is just using the mobile networks that are available. And some of these mobile networks, again, have even gone to a greater extent, but then I still doubt the level of communication in that aspect in terms of health coverage, because yes, they do have. I know MTN has a micro insurance scheme, which of course covers certain aspects of health, like accidents, yeah, Ayo, they have the app called Ayo, or they run the digital platform called Ayo. And Ayo goes into say, hey, contribute $1, $2, $3 in dollar equivalents, or 1,000 francs or 1,000 naira, 2,000 naira, or Ghana cedis. And in case this happens to you, you get instant payout. Now, I am not so certain about the measures that they have put in place to generate this or trigger this instant payout. And that, of course, that is out of this scope. But now, focusing on this is actually going to, accelerate the awareness you're mentioning. And the help apps I mentioned, they are doing very well. They are growing. And now we need to promote them. We need to take them. So they are breaking barriers of physical location. They are breaking barriers of displacement. And we need to embrace this thing. If you are not communicating clearly that you do not need to displace yourself for you to get health coverage, then we are lacking behind on something. And I mean, at this point, or from this particular angle, we do not need the government involved in this. We are the problem. We need to find the solution to that. Thank you.
Okay, thank you so much. I think you've mentioned quite a couple of points, and I'm happy that you said it's good to also give ourselves grace because we are growing. Like I said, health insurance is something that is just really, really new and it's picking up in different forms and shapes, if I want to use that term. There are both conventional and non-conventional ways of health insurance.
Exactly.
So let's deviate a little bit and let's move on to gender. I know most of us may be wondering, how does gender relate to universal health coverage and all that? So we're going to be having somebody very experienced in the field, in the person of Dr. Taiwo. So Dr. Taiwo, let's quickly get into what role does gender play in achieving universal health coverage? I mean, what is the relationship between gender and universal health coverage, if there is any?
Thank you so much. I hope you can hear me well.
Yes, sir, we can hear you.
Okay. Yeah, thank you for inviting me to participate in this webinar. My name is Taiwo Elade. I work at the WHO Regional Office for Africa in the Gender Equity and Human Rights Unit. I mean, simply for those who do not know about gender, because there's a lot of misconception around this area. Gender simply means the norms, rules, and relations amongst and between people in a particular community. So norms is what the community has taken as normal things that should guide the community. Rules is the
other way.
roles that men and women, boys and girls play in the community, and the relations, talking about the relationships. So these norms, rules, and relations in themselves, they are not, specifically bad, but in communities, we have placed some premium around these norms, rules, and relations in the sense that both the negative and the positive aspects of it are really amplified, and they have impact on individuals, families, and communities, and their access to and use of its services. Let me use a specific example. Let's use example of attendance and antenatal care. In most communities in the African region, because of the norms in the community, a woman is not expected to take that decision to attend antenatal or to start attending, to continue to attend on her own. Even if she's in danger, it's expected that the normal thing is for someone, either the husband or the husband's relations or her own relations, to make that decision for her. The rules where they come in the area of gender is that men are expected to be the decision makers. They are the ones who holds the pulse in the family. Again, if a woman is not working, she's a full-time housewife, for her to get the money to attend antenatal, either for transportation or to pay for services, she has to depend on the man. If the man does not understand why she has to do that, then she will not be able to attend antenatal care services, even when she knows that she has to, and she's having problems. So the relationships, again, very close to the roles. One person is the decision maker, the other is subordinate. If you put all this together, if we do not factor these gender issues into consideration, we are not going to achieve universal health coverage. Because most of the time, these issues are more amplified in the areas where the services are more or mostly needed, in the rural areas, in the urban inner cities where you have the poorest of the poor in the urban slums, and among the people who are really marginalized, either due to their ethnicity, their religion, or their age. Take, for example, a pregnant adolescent. Because of her age, she will not be able to make a lot of decisions on her own health, and then she will miss most of the essential services. That also applies to the adolescent boys. They're also stigmatized in a way. We most of the time blame the adolescents, whereas no one has really guided them, but we expected them to take the right decisions. And then we also expected that they behave like a man, in quotes, which leads to some form of toxic masculinity, violence, accidents, and all sorts of things that will happen because of the norms, the roles, and the relations that we expect from that group. That also extends to the older people who are no longer vibrant and able to really make decisions on their own. In most societies, they are abused and they're neglected. So all in all, if we are pushing to really achieve universal health coverage by the target date, we have to look at the people we do not reach routinely. Those are the people that are really left behind. The poor people, young people, the older people, and people who are in rural and hard to reach geographical areas. So most of the issues they really battle with are related to gender, being a man or being a woman, and what is expected of you in your community. So in order to shift the needle, to be able to reach these marginalized groups, we really have to think of the issues that they are faced with, address those issues. Then we'll be able to add that coverage to the people we are reaching traditionally, and then we'll be able to move in an accelerated manner towards the achievement of universal health coverage. Thank you.
Yeah, thank you so much. I think there are lots of things that I was able to pick, especially with the fact that looking at it through a gender lens, it actually does make sense, because oftentimes we are so focused on the already well-defined populations, we are so focused on the health aspects, and we tend to neglect significant factors like the gender, like you correctly explained. So now, in an era where most people think gender-based health approaches are mostly tailored to favor women over men, because most people, when they hear gender approaches, the first thing is women rights, women equity, women equality. So it's such an era where most of these gender-based health approaches, they are tailored to favor women over men. What can be done to really counter this narrative and ensure a gender balanced approach to achieving UHC. Like you've correctly mentioned, especially that of the teenage boys, where they're just expected to man up without any formal or informal training. So what can really be done to counter this narrative to make sure that we have a gender balanced approach to achieving UHC?
Yeah, thank you. I think the first thing is we have to shift the paradigm. We have to frame gender in a way that everyone will understand. There's a lot of misconception around this area. In some instances, when you mention gender, people equate it to LGBTQ issues, which is not the case. So in order to have a gender responsive paradigm to health, we have to really reframe the issues and create a lot of awareness. We assume a lot that people understand the meaning of gender, but there is a lot of misconception around this area, and this has led to a lot of anti-right movement and groups attacking the issues of gender. Gender does not refer to men alone or women alone. Gender issues means considerations based on sexes. So it applies to men and to women. And both men and women are really held, they are lagging in their head decision making. For example, we have been to a lot of countries where we have focus group discussions with men, and it's really, really very disheartening that that majority of the men don't even know what antenatal care is all about. So how do you help these men? And they also said they would like to know, but they are not included. If they follow their wives to the hospitals, most of the time the nurses tell them to go back, that this is not a place for men. Go back, come back for your wife when she's finished. So with that kind of orientation, you do not expect the men to participate fully and to really understand, because we have excluded them, and then they continue to hold on to their misconceptions about everything, and sometimes they trivialize issues, which may go on to, some men losing their wives and children and other. So we have to frame these issues in a different way. We have to ensure that the narrative is very clear. And then when you really explain these issues to men, since I've been working in this area for close to 22 years, I've never met a single man that says, no, I do not agree with this, when you explain to them. So the summary is framing. We have to frame the issues around gender differently. And the language that we use and the way we interact with the community also matters a lot. We have to balance the messaging, and also to really let the men know what we are talking about and the roles that they can play. For the women, they also have to know that these issues are, related to both men and women, because some of the harmful traditional practices, the gatekeepers are actually women, like female genital mutilation, teenage marriage, and some other issues. So when we frame the issues differently and we speak the language that the communities will understand, I think we'll be able to move the needle and accelerate efforts toward the achievement of universal health coverage.
Thank you so much, Dr. Taiwo. Please, if you have any questions so far, you can just drop them in the chat section. Now we're going to be moving to a very common yet highly controversial topic, which is HIV/AIDS. Most of us are probably, if not all of us, are probably aware of what HIV is and all that. So we'll be calling on Dr. Patrick to take the limelight. And it is interesting to know that despite the vast information on HIV/AIDS, despite the high amount of health education that has been around this particular subject, there's still a lot of discrimination. There's still a lot of stigma around HIV/AIDS. But in this session of today, we're going to be talking about how we can transition from donor dependency to sustainable domestic funding of HIV/AIDS program, because we cannot deny the fact that HIV still remains one of the top prevalent diseases in Cameroon and most African countries. Yet most of the funding for such a program comes from external sources. And the recent Trump saga that happened this year left a lot of health workers without jobs, and also had left a lot of people living with HIV having difficulty accessing their medication because most of it were funded from external sources. So we're going to be having Dr. Patrick shed some light on this. And the very first question I would love for Dr. Patrick to answer for us is, who are the primary funders of HIV-related programs at regional level? And what sustainability lessons can be drawn from large-scale donor-supported programs like the PEPFAR and the Global Fund? Maybe you can just shed more light on what, I'm sure people will be wondering, what is PEPFAR exactly? What are some of these donor-funded programs? Who funds HIV really? Let's just start from very basic. Who are the primary funders of some of these HIV treatments that we have at our disposal?
Good evening once more. Thanks, like you said earlier, I'm Dr. Patrick. I've been working in the HIV sector for a while now, about 7 years now. And your question is pertinent. We are just from celebrating Universal Health Coverage Day, and Cameroon is implementing, or in the first phase of implementation of Universal Health Coverage, which was launched in 2023. So we are having a little bit of challenges in it, and we are trying to implement it, especially for the vulnerable populations. So coming to your question, when you're talking about, or when you're asking about the major funders when it comes to HIV, I think many people here would have already heard about some of those names because they are the common names. We have the PEPFAR. PEPFAR has been like the major funder. PEPFAR is from the United States government, and it's actually a major funder for HIV and AIDS. It has always been in the past decade, or in the past 2 decades, 3 even. Then you have the Global Fund. The Global Fund too works. It pulls resources from a lot of nations, puts together, and it funds HIV programs in different parts of the world, especially Africa, specifically Cameroon, like we are talking about in this context now, what I'm talking about. We equally have the other governments. There are governments of European countries, there are governments like France, there are governments like Germany, Netherlands. Those ones in particular will pay particular attention in different aspects of HIV. Then we equally have domestic funding. Domestic funding comes from the government. Like you said, domestic funding is supposed to be the major source of funding, but it is not. Domestic funding here is usually the minor part of it, because the funders have been doing a lot, if we are to be honest. Then we have some private and corporate funds. We have the major foundations like Bill and Melinda Gates Foundation, who equally, if those are the major funders when it comes to HIV in Africa and HIV in Cameroon also. So they do a lot. But now, like you said, you mentioned when you were talking about the Trump saga, it's a reality. Everybody heard about it. Everybody who watches the news or listens to the news heard there have been challenges, drastic changes to funding. There have been cuts, there have been reorientations, there have been a lot of things that have been going on. With all those things going on, to be honest, the major people who suffer from it are the people who these services are supposed to be provided to, the patients, especially. those who participate in these programs, those who are supposed to benefit from these programs. Now, when we talk about the reorientations in themselves, they could be good, they could be bad. It's not our place to debate on that here. But we'll talk about the cuts. The cuts have been detrimental. They have caused a lot of damage. They have caused a lot of loss of life. And now things are getting a little bit better because the funding has been cut, but the funding was reinstated partly. So a few people benefit from these things as much as it was before. So we're talking about sustainability, about all the programs. There, it's also a topic which is complex when we're talking about sustainability of this program, because we have been used to having these donors pumping in money into our environment, pumping in into the healthcare system. So when these cuts arise, even when the government is willing, it takes time to raise that kind of money, because the money they bring in or they brought in was not small money. It's in millions of dollars. So the readjustments are drastic. So when we're talking about sustainability, there are a lot of things that go into sustainability. We have the capacity building that those programs were supposed to and started bringing about, because people have to be trained. People have to definitely pick up when those programs leave. But that, in essence, was not really done. So there are other aspects to it. But when we're talking about the impact of those cuts, we are talking about lives lost. We are talking about families where the primary supplier can no longer bring in anything to the family. So it's really a sad situation.
So I'm just a bit curious. For a problem as significant as HIV, and we have like this, like funding, like it's support. It's not supposed to be the main source, but it's supposed to act as a support. And like you mentioned, the cuts led to loss of life, loss of employment, the source of livelihood on the part of some health workers. Now let's look at a scenario where this kind of cuts was not reinstated in some way, like it was maintained at the level at which it was. That means the cut was maintained at that level. There was no form of reinstatement or anything. How as somebody who has been in this field, how do you think the government will be able to maneuver? Because you did mention about universal health coverage phase 1 that was started in Cameroon, which is a good initiative, but so far we've not seen any reports. I've not read any report anywhere. I've not seen the promised phase 2 is yet to manifest. So imagine such a cut was not reinstated in any way. Just based on your experiences, how will you rate the survival rate of both people living with HIV that are dependent on these funded programs, and also the survival of the health workers who are permanently paid by or supported by these funded programs?
In terms of employment, firstly, there will be drastic loss of employment, because those health programs, the donor programs, when they come in, actually they pick the best to work for them. They pick the skilled medical doctors, they pick the all those who are implementing. The implementing partners, actually, when you go for the interviews, it's tough. It's a tough process. So they pick out those people. So when those people find themselves without jobs, it's not just about livelihood for those people. It's about the people they serve. So the impact is going to again be on the patient, because those people are the ones who are in charge of the largest HIV treatment centers. HIV treatment centers are divided into tiers in Cameroon. Let's talk specifically about Cameroon. It's what they call tier 1, tier 2, tier 3, tier 4 HIV treatment centers. Tier 1s are the ones who carry 2,000 and above HIV, people living with HIV. Those skilled workers who work for implementing partners work in those tier 1, the doctors. So if you find an HIV treatment center, for example, that carries 4,000, 5,000 people with HIV, has a skilled doctor, and usually is one doctor to serve that population. So there's really a problem with understaffing, even from the implementing partner, because he works with the budget which is given by usually CDC or any of those other funders. So when you have those people losing their jobs, they cannot serve those populations. 5,000 people will not be catered for. If you do that, across the nation. You can imagine the number of underserved people living with HIV. Now, when it comes to, because those people put in strategies, when those strategies cannot work, people will miss their dates for medication pickup. And even the ones who come to the hospital and are sick will not be able to have a doctor consult them. They are going to progress to advanced HIV diseases. They are going to die. They are going to transmit the disease because they're going to have high viral loads. So we go back to the public health gains we have had over the years. They get reverted in a very short time. If we had gained significant changes in about 10 years of these donor programs existing, to revert those things, it takes about 2-3 years, and we go back to where we began. So in all of these, the cuts are really something which is we can even use the term, the adjective dangerous. It's dangerous for a lot of people, and it's very, very challenging to handle these cuts. But what was supposed to happen is the governments of these countries were actually supposed to step in when these cuts happen. When these cuts happen, governments were supposed to fill in that gap. But like I said earlier, filling in the gaps is not something easy. It's not something which is done in a day. The budgets already of the years were planned. And after the plannings of the budgets, then there were things that had happened after that. So to plan the budget and then to redirect funding from another sector and put in the healthcare sector and as an emergency is very, very challenging. So with all that, it's a multidisciplinary approach, like we say in medicine. Everybody is supposed to put hands on deck, contribute, civil society, private donors within the nation, not just out. So we're talking about donors we see from external, but within the nation, they can be also donors. But that has not been worked on in our environment, to be honest.
I'm just really curious, for a problem as significant as HIV, why do we still rely so much on external funding? What is the challenge with, because I don't really understand, for a problem that has been there for decades, that is a problem. And you made a very important sentence that progress that has been made for 10 years can easily be reverted in 2 years because of cuts. And we find ourselves back in square one, all the numerous 90 goals, 95, 90, all those things they become meaningless and insignificant in the face of such an experience. So what, in your own thinking, what do you think is the challenge? Why are our governments just really heavily reliant on external funding? What is so difficult for us to be able to, or what needs to be done exactly for us to be able to take charge of our, because if we're talking universal health coverage, we can't be relying so heavily on external funding, because situations and scenarios like this is not the first time, and it's definitely not going to be the last time.
I think I'll surprise you with the answer, but I think the answer to this is just lack of will. You see, in 2001, there's the Abuja Declaration where African nations, they committed to spend 15% of their budgets on healthcare, in all aspects of healthcare, especially primary healthcare, because that's what we need in Africa, especially in sub-Saharan Africa. But the problem is, those things were written, they were signed, ratified by the government, but implementation has just been the problem. So in my opinion, it's lack of will. Because we have all the beautiful strategies written in documents in Cameroon, written and pasted. You enter even hospitals, you see they have put charts and everything of what is supposed to be done. You spoke about the phase 2 of universal health coverage that has not kicked off. That too is a problem. Phase 1 is still ongoing. Phase 1 has had problems, but communication too is another problem. We don't even hear about it.
Yeah.
You see, sometimes it disappears. Even the doctors in hospitals just see, and if you ask a doctor what is universal health coverage, to actually tell you about it, so many of the doctors will be lost. They will not know how it works. They don't know how it functions. So I think it's just the will. If our governments realize healthcare is as it is supposed to be a priority, there will be a shift. Cameroon spends about 3%. Last year it was 3.9% of its budget on healthcare, which is far from the 15%. So they have been just reliant on the donor programs and the funders and all of that, which in itself, because the money was available, it used to cover a lot of things. We could not see many things, but now the money has reduced. Stepping up, since you're used to a particular thing, habits are difficult to change. But I think with a lot more commitment and will from the leaders and government, they could change that very easily.
Okay, thank you so much, Dr. Patrick. Now let's move to a regional body in the house. Obviously, we'll be speaking about lots of funding. Why are we dependent on external funding? Why are we not using our internal resources? Now we're going to be looking at one of the, should I say, the regional bodies when it comes to health in Africa. So we're going to be having an epidemiologist on the limelight in the person of Mr. Sebastian. And we're going to be literally just having discussions about UHC and with respect to the role that African bodies like the African CDC are currently playing, or just to shed more light on that. So, Sebas, the first question I would just literally want to ask is, post-COVID-19, all of us are aware of how COVID-19 really, really affected not just economics, not just health, but so many things changed post-COVID-19. So how has the COVID-19 pandemic really reshaped our understanding of what universal health coverage must include in Africa, particularly when it comes to surveillance of disease, emergency preparedness, and just the health security infrastructure in general? So we're looking at post-COVID-19. How would you rate Africa's journey towards universal health coverage before COVID-19 and post-COVID-19? Sebas, you have the floor.
Thank you, Rita. Sorry, can you get me?
Yes, we can hear you.
Okay. Hi everyone. Joe Sebastian, I'm an epidemiologist with Africa CDC. I'm an epidemiologist, but with Africa CDC, I work as a senior mining officer, for Africa CDC. And just going up, with the theme of today and adding, shedding more light to what other participants have spoken on. Just to respond directly to your question on that, COVID-19, how can I put it? Is something non-negotiable that COVID-19 has actually shaped, universal health coverage, specifically in Africa, and it has fundamentally expanded, its definition of universal health coverage in Africa. Yeah, I want to say before the pandemic, you agree with me that universal health coverage debate, focus mainly on service delivery and financial protection. But COVID-19 has, shown us that without strong public health functions, universal health coverage collapses under a shock. So, if you look at the World Bank's scorecard, you see that, okay, over 70% of countries did experience essential disruption of the essential health services, during COVID-19. Likewise, weak surveillance, laboratory networks, genomics of that, oxygen systems, emergency coordination, translated directly into preventable deaths and economic losses. So to an extent, we want to say that this was actually something that was preventable if our system were actually very strong and resilient. Yeah. So I don't say that one of the key lessons for universal health coverage in Africa is that disease surveillance, emergency preparedness, public health emergency operation centers, laboratory and genomic capacity, supply chain resilience, are not just add-ons, but but are actually very core components of universal health coverage, globally. And just to conclude on this point, I'll say the COVID-19, actually exposed, our major weaknesses in health systems, while accelerating critical reforms. The pandemic actually highlighted gaps in, financing, workforce, capacity, infrastructure, and was that, and also equitable access to care. Yeah. So underscoring that universal health coverage was far from fully achieved. At the same time, it also elevated, universal health coverage as a political and economic priority, if I put it that way. Yeah. So I believe if we have a strengthened primary healthcare system, community-based services, improve disease surveillance, and digital systems, and also integrated pandemic preparedness into universal health coverage planning, we better have, let me say, we'll improve our universal health coverage index. Yeah.
Okay.
So yeah. So also the pandemic, let me also put it this way, that it also kind of revealed, deep inequalities and reinforce the need to leave no one behind, put it that way, while ensuring regional cooperation, through institutions like Africa CDC. Like, if you can remember, during the outbreak, 2019, though we declared the emergency. 2020, we're totally dependent on the West, for vaccines, all of that. Yeah. So I would say overall, COVID-19 actually transformed Africa's universal health coverage, from a long-term goal into an urgent necessity, let me put it that way, yeah, for building resilient and inclusive and sustainable health systems. So Africa CDC, likewise, has reformed universal health coverage, not just Africa CDC, like, not to leave out, WHO, whose mandate is global, but Africa CDC focuses, on the continent more, has actually reformed universal health coverage as an inseparable component from health security, while strengthening continental surveillance, laboratory systems, all the networks, genomics here, emergency response, and and coordination through emergency preparedness and response. Yeah.
Yeah, thank you. There's something I picked that you said, post-COVID-19, it has made us actually understand that universal health coverage is no longer a long-term goal, but more of an urgent call for action. So looking at infrastructures like the African CDC, for example, I'm sure many people will be wondering, what are they really doing when it comes to achieving things like universal health coverage? What kind of, is it that they play a role of supervising African countries under their mandate to achieve universal health coverage, or they have like some kind of specific laws or rules or policies that are governing UHC? Because like Dr. Patrick said, Cameroon's score was 3% out of the 50% when it comes to the state budgeting that is supposed to be allocated for health. And I think if you go across most African countries, you will find that most of them are not even up to 10% of national budgeting when it comes to. So does the Africa CDC have a role in emphasizing or putting a pressure that, okay, this is what's supposed to be done? Because now we're talking about UHC, and we're talking, this is a regional body that is well respected, obviously, for their credibility and all that. So what is being done at those of us that are outside the Africa CDC? Maybe we're curious, what are they doing with regards to this? Because we have just 5 years to go. And African systems have always been termed as fragile, as delicate, as highly dependent, like you mentioned, post-COVID-19. We have even moved back because people are not even longer willing to take vaccinations. Post-COVID vaccination willingness we've seen a lot of resistance to vaccines post-COVID because of the whole saga and all that. So what is a respected body like the African CDC, what are the steps? Are they like a supervisory body? Are they ensuring that governments are actually moving from heavy dependency to local sustainability? Like, just give us that idea, that picture, so that we can know that, okay, if somebody leads it to everybody and they ask them, they can proudly say, yes, the African CDC is doing something. They're not sleeping.
They were not sleeping. Yeah, thank you so much. That's a tricky one. So basically, Africa CDC, being a continental organization, they actually plays a very critical catalytic role in accelerating progress towards universal health coverage. you want to agree with me that this is also a very important component of the I'm missing this word, the Sustainable Development Goal theory. Yeah, good health and
Yes,
well-being, focusing on yeah. So it actually focuses on ensuring that service coverage and financial protection are sustained through public health systems. And if we look at for example, we are trying to ensure that the universal health coverage index, which is actually a composite indicator, it was actually developed by WHO and the World Bank, to measure how well a country population, receives essential health services. So currently it stands at, I think it's 71, at 71. That means that essentially out of a score of, let me say, of all the basic, basic health services that is supposed to be a country is supposed to deliver, to its population, globally they're receiving, let me say 71. This is not limited to you have infectious disease, reproductive health, maternal and newborn, all of that. So we had focused at Africa CDC to improve this index, way to a significant figure, close to, let me say above 85, more significant. Yeah. So while the sustainable goal theory, for example, focuses more on access to essential health services and protection from catastrophic health expenditures, for example, Africa CDC strengthens the foundation that makes this possible. Notably, as I said earlier, we focus more on surveillance, laboratory networks, emergency preparedness, health information systems, and workforce capacity. So also by supporting the public health emergency operation centers. So in each country, for example, if I take Cameroon, they have what we call under the Ministry of Health, we have what we call the National Public Health Institute. The francophone countries, they'll have what we call the Institut National de Hygiène Publique. That is the National Institute of Public Hygiene, and you have National Institute of Public Health. So that is where we have the public health emergency operation centers. So most countries were actually lacking in these. So far, Africa CDC has supported over 30 member states to establish in establishing their public health operation centers here. Coordinating response to more than 100 outbreaks annually in Africa, and promoting integrated primary health care and preparedness. So Africa CDC also helps countries protect routine services, during shocks, prevent cost disruption, and that push households into poverty, trying to cater for, let me put it, to reduce out-of-pocket expenditure. Yeah. So like, for example, if you look at the out-of-pocket expenditure in Cameroon, I think it starts at 70%. Yeah. That means that if you look at ideally, that means that ideally for Cameroon, if you look at the total health expenditure, that is paid directly. If you look at the total health expenditure for Cameroon, 70% comes from the household. That is, the population spends from their pocket. So we, through all of these integrated efforts, we are trying out, to reduce that gap, that out-of-pocket expenditure. Just clean up on what the previous speaker, sorry, I missed his name. He did speak about the government health expenditure being at 3.9%. So if you look at the expenditure of the government per year, that's for last year. That's actually what is on the World Bank's scorecard. If you look at it for Cameroon, we are at 3.9%. That means that it's basically, if you look at the government has spent just 3.9% of its total country's economic output. Of all what we have achieved in Cameroon, as our GDP, we have spent just 3.9% on health. So we are trying to improve, to actually, support, member states, to increase that that percentage. Likewise, reduce out-of-pocket expenditures. So also, just to mention that we now have what we call a new public health order. So, and through this new public health order, Africa CDC explicitly aligns health security, local manufacturing, data, and domestic financing with universal health coverage goals, reinforcing, the message that, the SDG goal 3, cannot be achieved without resilient, self-reliant health systems. Yeah. So by actually operationalizing this agenda, that's the new public health. Yeah, Africa CDC positions preparedness, health security, not as parallel efforts, but as foundational building blocks. Yeah, for sustainable universal health coverage in Africa. Yeah.
Wow, thank you
Thank
so
you.
much. Thank you. I didn't know the Africa CDC is doing a lot. So just rounding up with you,
You
do
can
you
actually, just to say, you can actually check on the website. I can share that in the link. We have a strategic plan, from 2020 to 2030 with our priorities there. You see that clearly aligning it. Yeah, over 6 priority areas, and let me say 13 though. Yeah, 6 priorities and 7 enablers. Yeah.
Okay, so we're actually rounding up the webinar. My last question, my parting questions to you is, do you think UHC is possible in Africa? We've spoken about all these things, how beautiful the mandates that are going on, the pillars, the projects, and all that. In a very realistic one sentence, do you think universal health coverage is achievable in Africa?
Yeah, I think universal health coverage is very achievable in Africa. If one, we get to improve on sustainable domestic financing and reducing reliance on the West. For example, I take on the COVID-19 situation again. If we are able to improve on our own domestic manufacturing, that is actually going to improve on our universal health coverage service index. Let me put it that way. Yeah. So I think if we can focus on these key points, improve them, is actually something very, very realistic. We can actually achieve that. Yeah.
Okay, and the last question, if you were to implement one policy change across Africa, if you were to implement one policy change across Africa, now, if you were given that wish stick, and they said you should implement one policy change across Africa that will accelerate her progress, that's Africa's progress towards achieving UHC, what would that policy change be?
We focus more on local manufacturing, as I said earlier, local manufacturing, sustainable domestic financing, and good data. Yeah. So let me still come back to this priority. Yeah. So though, if you look at, for example, our strategic plan for priority 6, we focus more on expand health product technology innovation and manufacturing, directly, challenges the long-standing narrative of, fragility by positioning Africa as a producer, innovator, and informed buyer at its own health solutions. So if we can change the narratives of, so depending on the ways, scaling up local manufacturing, sustainable domestic financing. Yeah, I think those 2 pillars specifically, we can realize a lot. Yeah.
Okay, thank you so much, Sebastian. I think you can just share the link of the Africa CDC pillars in the chat section, so that those that are interested can look it up. Now we're going back to Mr. Lowe. I don't know if Mr. Lowe is still with us. Mr. Lowe, just 2 questions and then we round up with you. Do you think, from your perspective as a health insurance expert, do you think UHC is achievable by 2030?
I'm going to be honest, I don't think so. Yes, and I'm not going to give you specifics or throw the blame at one particular group or sector or individual. But I think contributory, everybody is involved, from the government to even the patients themselves. I'm just going to give you one example that elaborates my point. Health insurance worldwide, and to be more specific in Africa, is struggling. Why? Because of its implementation and the fact that you will notice policies are becoming stringent, the conditions are becoming stringent, and it seems it's not in favor of patients. However, who are the cause of this? They are the patients themselves. So if health insurance was regarded as one aspect that could accelerate universal health coverage, it becomes a challenge because we are pushing the players of health insurance space to make the conditions even tighter. And I wouldn't want to use the word, but the dishonesty comes into play in this aspect with the fact that people are not willing to declare what is happening, or trying to swap policies. And in this aspect, when it happens, it becomes a challenge, especially when now the insurance players, they get to realize that the next time they are issuing policies, they become harder and harder and harder. And therefore, one of the ways insurance becomes harder is the increase in premiums. And when the premium increases, we know what is happening. We will have lesser people subscribing for them. And when lesser people subscribe for them, it means the other population has been sidelined. And then that brings the coverage, universal health coverage, is difficult.
So
Thank
if you were to be given the same wish wand and asked which one policy you would implement across Africa to speed up universal health coverage achievement, what would that policy change be?
Okay, I'm going to design frameworks or policies that are going to enhance local players. We have, like I mentioned earlier, digital players, we have the insurance players, we have even the health sector. So anything that's going to raise incentives, of course, I would want to subscribe to that. Secondly, enforce regulation, because now you can raise incentive, but those benefiting from those incentives do not pass this across. So enforce regulation to make sure that the incentives gotten are actually applied. Thank you.
Thank you so much. So we're moving over to Dr. Taiwo for your parting words. Dr. Taiwo, do you think universal health coverage is actually achievable in Africa?
Thank you very much. I am a very optimistic person. I think nothing is impossible in this world, but there's a caveat. If we start to do the right thing from now, and that is, it has been demonstrated that primary health care is the bedrock and the foundation for which we can quickly achieve universal health coverage. Across Africa, you see a mixture of policy directions that are not really specifically focusing on primary health care. A lot of countries that are struggling to really fund primary health care are investing heavily in tertiary health care, importing high-tech equipment, building facilities that most of the populations would not have access to. So if we turn from that and we focus on primary health care faithfully, we go back to the real definition of primary health care and we implement all the components, I think we will make a lot of headway before 2030. Specifically, if we look at the framework, the approach has identified 3 major areas: integrated services, empowering people and communities, and the multi-sectoral policy and actions. So if we look at the 3 foundational approaches, and then we try to understand what are the barriers to, implementing these approaches to scale, identifying the major barriers, which will be different for different countries, but most of the time, they are mostly, the underlying barriers are around gender equity and human rights, where a specific population is inadvertently neglected. If we use this focus on all the 3 strategic approaches for primary health care, identifying who is left behind, where they are, why they are left behind, and then working, because addressing universal health coverage is not only in the purview of the health sector. Other sectors have a lot of roles to play. For example, water and sanitation, finance and economics. You have housing, roads. So all these are really determinants of a universal health coverage. If we focus only on the health sector, we are not likely to achieve universal health coverage. But when we have an intersectoral approach to universal health care, and then we're able to identify the people that are not currently having access, if we're able to, in some countries, they're up to 50% of people, some 40, some 30. If we're able to really address these people that are left behind and ensure that they have access and they're adequately covered, 5 years is more than enough for the countries to really address these issues. So that is the condition. If we are ready to achieve universal health coverage, we have to focus on those who have been left behind, identify why, and work with other sectors in order to address the issues that are holding them back. Then I'm sure we'll be able to move in an accelerated manner towards universal health coverage by 2030. Thank you.
Thank you so much, Dr. Taiwo. And finally, Dr. Patrick, do you think universal health coverage is achievable by 2030? Do you think? Honestly, just a personal opinion.
Well, like Dr. Taiwo said, I'm equally an optimistic person. But that timeline of 2030 for me, I think is too soon. Because universal health coverage to be achieved needs a lot of things. When there's, first of all, a limited will on the part of the government, a poor understanding on the part of the main beneficiaries from it, it's not a good mix for us to achieve it in the time needed for us to achieve it, because we're in 2025, which is running out. So basically, we just have a few years to achieve it. So I think the timeline is going to be challenging for us to achieve it then, but I think it's possible if we have the right mix in our context.
And what is that one policy you would implement to speed up universal health coverage in Africa if you had the chance to?
Like they always say, nothing is new under the sun. The strategies are already in place, but the strategies are not implemented. I'll come back to the same Abuja declaration.
Yeah.
If government increase the spending like it's supposed to be to 15%, and when at 15%, this is supposed to be actually followed up in the sense that they are supposed to be accountable for the money, those who spend this money. If the money reaches the right people, the money is channeled to the right programs, I think we can achieve. And the money is spent on primary health care, because the problems we have is investments are made, but investments are made in areas that don't really need to be. Because you have children dying of malaria 0 to 5 years every day. You have vulnerable populations dying from this. The government invests in things like building intensive care units, those things are very necessary, true, but we should shift priorities.
Yeah.
Put the money needed. If we can do that, focus on primary health care first, make it a priority, invest that kind of money, which is already on paper, into those areas, then I think we can achieve universal health coverage.
Thank you so much. And O'Brien in the chat said, indeed, while UHC is a great stride in healthcare, it's clearly obvious that absolute attention of UHC is overly ambitious and unrealistic, especially with the 2030 deadline. As such, most scientists advocate for the use of the term towards UHC instead. Indeed, it's a very ambitious target or goal, and if we are all trying to be optimistic, we can say if we put in the right strategies we've heard from the different panelists, if we are willing, if the governments are willing to put in the right strategies to respect the Abuja Declaration, then it will be very, very important. I think UHC can still be achieved. I mean, we are making strides, we are making progress. Let's give ourselves a little grace. We are making progress, even if it's not so significant. It is something that is achievable and is doable if we want to. So if you have any questions, you can ask. I think Sebastian has also dropped the link for the Africa CDC strategic plan and also other normative strategies. If you're interested, you can just check in the chat section for the link and copy it before the session is ended. So I want to thank all the speakers, honestly, for doing justice to the topic. Universal health coverage, like they say, it's a topic that is very close to home, yet still very unfamiliar to many people. As basic and as simple and basic as the topic is, many people are still not aware of what exactly universal health coverage is. So it's just a mandate for us to go back home and do our individual researches and see exactly what is happening in the planet. And in as much as we can confidently say, oh, other countries are already making significant achievements, what UAC, I think we are capable of doing it if we are willing. So if there are any questions, you can please ask. Yes, thank you, Marita. Marita says many thanks to the panelists. It's time to shift the needle from policies to implementation. Indeed, we already have thousands of policies that are well archived and well written, but implementation has always been a problem when it comes to Africa. So it is indeed something worth taking home. So thank you so much again to all that attended. Thank you to all the panelists. If you have any questions, you can always reach out to me, or I can share their emails with you after seeking for permission. You can always network with them. You can reach out to them.